Good evening, everyone. Today we are planning to discuss upon the latest DNB question paper of pediatrics held on 15th May 2024. That is the paper 1. So this is in regarding to one of my subscriber students who asked for some guidance on exam on how to approach it, and especially on the time management, how to highlight important things, and how to approach an unknown question. So I thought this is the best opportunity to introduce the latest question paper pattern as well as to guide on these points. So let's go to the website. Yeah, we open our materials. So here we enter the OTP. The courses may reach out the materials. At the end, you see the DNB Pediatrics May 2024 paper 1. So it's been fully uploaded after solving. So let's discuss each question one by one. For ease of editing, I will take the help of the Word file. So the first question asked was on human milk fortifier. This is a standard previous year repeat question. It was from neonatology and it has been discussed in the chapter on neonatology in page number 167. Here what you are supposed to actually discuss is the purpose of using human milk fortifier. Why actually you want to enhance the nutrient density and support their growth, and what are the types available. One is the powdered form, liquid form, and some are human milk based and some are cow milk based. Human milk based are actually very expensive, so cow milk based are commonly used. The Lactodex is the commonest brand which you might be using in your hospital. Next comes the indications for use, and main thing you need to highlight is the both micronutrient and macronutrient requirements which are not met by milk feeding alone will be met by using the addition of human milk fortifier. What benefits the newborn achieves, and what are the need for these fortifiers? What would be the consequences if you don't fortify, where there will be suboptimal growth, neurodevelopmental impairments, and micronutrient deficiencies? And also the timing of fortification, when to fortify. It is early fortification versus late fortification. You need to discuss a few lines on that. And the target population, as I already mentioned, the preterm infants weighing less than 1500 grams. Once you start fortification, what are the nutritional enhancements achieved through this fortification in terms of protein, energy, minerals, vitamins, and micronutrients? What are the long-term benefits in terms of improved growth trajectories, enhanced nutritional and neurodevelopmental outcomes, reduced incidence of morbidities, and the practical aspects like how will you mix, how will you administer, and what will you monitor when you are giving? What are the potential issues like intolerance, allergy, and infection risk, how to handle that? So this all completes the first answer on human milk fortifier. The next question asked was the anti-infective properties of breast milk. This is again a standard question previously asked and has been answered in the chapter on nutrition and malnutrition, page number 31. So we'll enlist all the anti-infective properties present in human breast milk, starting from IgA, IgG, and IgM in very little quantity, and lactoferrin, lysozyme, oligosaccharides, cytokines, various growth factors, fatty acids, hormones and peptides, enzymes, cellular components, nucleotides, and we need to discuss each of them. And also sometimes if you have extra time, you can even write upon what particular component of the breast milk protects against which organism. That also list is available, and this part has also been asked multiple times in NEET SS. Like for example, PABA or the para-aminobenzoic acid, which protects against Plasmodium vivax. So that would complete the answer. So the next question was on statistics, the randomization in the trial. This is an extended question, I would say, because in previous few papers, steps of RCT has been asked. So in the RCT, that is randomized control trial, randomization is one of the important steps. That is the cornerstone or the heart of the clinical RCT. So what is the purpose of doing randomization is to eliminate bias, so that the division of the two groups of our study population will be unbiased. That is the main purpose which we need to expand and give a statistical validity to our study. What are the types of randomizations that are available? Simple, block, stratified, cluster, and adaptive. And how to implement this. And what are the challenges like in imbalance, blinding, compliance, and dropout. And how do we actually apply it in the clinical trials with one or two examples in your hospital. If you have done an RCT, you can just quote that example. That would complete the answer. Next question was a little tricky one. It's on authorship criteria. It's an extension of the question asked in October 2023. In October 2023, they asked about ghost authorship and gift authorship. Now they have asked in May 2024, 6 months later, the exact full authorship criteria. What is this authorship criteria? Suppose you go to any PubMed article and you go for any article, this is how it will appear. They will have a list of authors. So this is my article and I am the author of this article. I am the first author of this article. So, and it is been published in a particular journal. So in pediatrics on this particular year. So to say that these doctors are the authors for this article, what criteria do we hold? Have we really done the research on that particular topic? Have we written the manuscript? Or is it like someone else has done and we are taking the credit of it? To filter out that, some criteria have been established. That's what has been asked in the paper this time. So various guidelines exist for this authorship, but one of the most accepted one is IMNCI. The criteria include all the contributions in the conception, design, acquisition of data analysis and interpretation, and drafting the article or the manuscript, and final approval and agreement of all the accountable people. And in additionally, there are some people who contribute to the study or the paper but do not qualify for authorship, for whom we acknowledge their contributions. So that also has to be mentioned. So what disputes may arise, like suppose someone else has done a study and you publish it in your name, then a dispute can arise. So then the authorship criteria will be tested. So this was an extension of gift and ghost authorship, which was being discussed in the previous paper. Coming to the next question. This is a new question. Open access journals, the advantages and disadvantages. Usually whenever we go for any article, we do find that all the articles are not available for full access. Some of them are paid, but many are open access. Suppose this particular article of mine, it is published in Pediatrics in 2016. And this is a paid article. Even I cannot access it without payment, though I have the draft of myself, but to access it from the journal, you may have to pay for it. So the question actually asks, is this open access journals, are they advantages or disadvantages? We now have to list all the advantages. One is the increased accessibility. Obviously, this is a new question. On spot, you have to decide and use an answer. And very common sense will tell you that increased accessibility is found in open access journal. Whenever you are asked to prepare a PowerPoint, you preferably tend to seek the data from the internet and you will download the articles that are freely available. So they are easily accessible and hence they have increased accessibility and the global reach, enhanced visibility and impact, faster dissemination, compliance with funding requirements. But disadvantages are the person who wants to publish an article of his own in the free access journal, that time in the article he has to pay a huge amount of money to get his article published in such open access journals, and it may be required from the author point of view for the purpose of his promotion. Say for becoming from assistant professor to associate professor, a person has to publish X number of articles. If that is a requirement of the university, then he will go for all this. That is the disadvantage. And since it is freely accessible, there will be no proper peer reviewing or editorial services in this particular group of journals, and some amount of variable impact, even they may have very low impact and sustainability. So those things have to be discussed on spot. This is actually an internet reviewed answer, but on spot you can think of all these points in the end of the paper and answer these. Coming to the next question from embryology of neural tube, discussed on page number 53 in CNS chapter. So I have drawn two diagrams. So one is the rostral neuropore wherein the pit forms and then it subsequently forms the neural tube, and the forebrain, midbrain, hindbrain, and the extension into spinal cord as a part of this neural tube. Main thing you have to explain in the stages of neural tube development will be a gastrulation and neurulation, especially the days, day 25 and day 27, especially after 21 days of embryo formation, then how the differentiation of neural tube occurs, the rostral and caudal part, and the three parts. And also, if you have good memory, you can even include the molecular signaling that happens during this particular process and its clinical relevance, that is the formation of neural tube defects and the role of folic acid. The next question is an extension of it, the prevention of neural tube defects. The whole answer revolves around folic acid supplementation, its recommended dose, and in high risk groups the dose would change to 4 grams, and the timing, when to start, when to stop, what is the mechanism of action, how does it prevent formation of neural tube defects is to be discussed in detail, and the genetic counseling, prenatal care including high dose folic acid, that is 4 milligrams daily. And but the answer does not end here. If you want to achieve more or full marks, you can even include lifestyle modifications and avoiding of alcohol, some of the recreational drugs, and medications like valproate. So suppose the mother is on valproate for seizure disorder, which are known to be teratogenic and causing neural tube defects, you may have to switch to another anti-epileptic. So these things you can mention. So if there is an extension of the answer, then you can mention the management of pregnancy with a previous history of neural tube defect in a child, then how to approach that particular lady. You can mention these points and when to monitor, what all tests to be done, like serum alpha fetoprotein. Coming to the next question, high flow nasal cannula. Remember, this can be very tricky. It was a repeat question from June 2021. The high flow nasal cannula in children, you can answer it straight away. Unless they mention it high flow nasal cannula in neonates, don't talk about neonates, because that is an entirely different concept and it has a lot of evidence behind it. So coming to the pediatric part, you have to write the principle of high flow nasal cannula, indications, mechanism of action, advantages over the conventional oxygen therapy, the equipment required and its setup, and its advantage that it is very economical and the blending can be achieved even with all our traditional techniques, and the cannula size based on the child's near, how you measure and monitor. So what are the safety precautions you need to take? How will you monitor a child on high flow nasal cannula, and the clinical evidence and guidelines behind it? If you discuss this along with the limitations, that would suffice. Coming to the next question, the question was on hypokalemia and clinical features and management. It is a repeat question discussed in fluid and electrolyte chapter, page number 3. You have to classify the severity of hypokalemia, mention the causes, etiopathogenesis, the important clinical features and the ECG changes, and the management. And the concomitant management like coexisting magnesium deficiency also that needs to be corrected has to be highlighted along with the other aspects, and sometimes use of diuretics like spironolactone, the potassium sparing diuretics to be considered. Next question was a relatively difficult one, the long QT syndromes. Previously the question asked was on tachy and bradyarrhythmias, of which one of the column was on long QT syndrome, but here they have asked the long QT syndromes in detail. So you have to classify them into congenital and acquired, and among congenital, the 3 types which involve 2 potassium channels and 1 sodium channel and the gene involved in it. This is a relatively difficult question, but I understand this is also equally important in SS preparation. So you need to remember this long QT syndrome, the pathophysiology, clinical presentation, diagnosis, and in the management, you need to emphasize on beta blockers, ICD, and those who are not eligible for ICD, then you have to go for left cardiac sympathetic denervation. Next question was from social pediatrics. It's a new question again. MCP card and its role in health check. So MCP card, or the mother and child protection card, here this is the front page of the card. That's how it appears, and what all it contains, what all the key features like personal information, health records, immunization schedule, the nutritional status, education and service utilization. How does it impact the child health? What all it will monitor, including immunization, nutrition, and growth monitoring, developmental milestones, and the schedule. So that part needs to be discussed. The important part which we should not ignore in this is the integration with other health programs and linkage to schemes like JSY, ICDS for comprehensive care and support. What are the challenges that this particular card is facing, and what possible changes we can expect in the MCP card in coming days? That also you can mention to complete the answer. This is actually found in NIH or NHM websites and Ministry of Health and Family Welfare websites. You can access the full article from there. Coming to the next question, kangaroo mother care. So this is again a previously repeat question discussed in neonatology. Page number I have mentioned 48 to 53. Define it and then mention the components from kangaroo mother care. Many of them get stopped at skin to skin contact only, but that does not end there. It includes other components also like exclusive breastfeeding and all. So do mention it. What are the prerequisites and what are the benefits for mother as well as baby by using the KMC technique, and the advantages and disadvantages. So that would complete the answer. Next question was adoption criteria of Indian parents. So this is discussed in General Pediatrics Part 1, page 8 to 14. And what are the eligibility criteria for a couple to adopt in India as per the rules? What should be their age and what should be their marital status, number of children they have, and registration, matching process. All this has to be discussed. Coming to the next question on early intervention and early childhood development. So this particular interventional activity is a conglomeration of multiple support systems like physical, cognitive, social, and emotional development of a vulnerable child who is prone to develop in an aberrant way apart from the normal way. Like we deal with many children having hydrocephalus, intrauterine central nervous system infections, or meningitis in the newborn period, or periventricular leukomalacia suffering lot of asphyxial changes. So those children actually need early intervention and for a better development. So what are the key components of this early intervention we need to discuss? The referral and initial contact, how to screen and select the patients, what are the eligible babies, and how to individualize the family plan for them. And once we make a plan, how to implement it and how to deliver the services and how to monitor the progress. So all this has to be discussed in the early intervention part. What would be the benefits of this early intervention? We will get better and enhanced neurodevelopmental outcomes. However, that would not be normal, but we can always mention that it would be better than the untreated groups and it would be near normal. So that will give a better family and a social position to the affected child. Coming to the next and very important question on the lab diagnosis of tuberculosis, discussed from infectious diseases. Now the key points which recent guidelines from the government of India and WHO they want to emphasize is to use of newer diagnostic tools which the examiner might be asking for, especially antigen based test, and the moving away from traditional methods like our Montu test. So that has to be highlighted here. How to approach a particular patient with suspected tuberculosis based on our clinical evaluation, then comes the radiology or the chest x-ray, microbiology, subsequently our newer diagnostic methods like CBNAT, antigen based tests like lipoarabinomannan test. Moving away from traditional test needs to be mentioned, and the policy guidelines by our national and WHO guidelines have to be mentioned here. So this is a table summarizing all the methods of diagnosis of tuberculosis, their relative sensitivity, specificity, and the comments and the principle used in the testing. So tuberculosis preventive therapy based on the prophylaxis, who is the target for this particular preventive therapy, how to screen them, and how to decide the duration of this particular therapy. Like in this table you can see these drugs and what should be the duration, and for who is the eligible population for whom this particular regimen has to be started, that needs to be discussed. Coming to the next question on MR campaign. This is the most repeated question in the recent times. It was asked in October 23, December 21, April 23, and among all that part, the MR campaign, which has been taken up with a great success by the government of India, now there has been increasing notable rise in the mumps cases in various parts of India, including Maharashtra and our Telugu speaking nation. So that part is a new point which I have added in the answer. Rest of that MR campaign would remain the same. So wherein you go ahead with the background and objectives, our campaign strategies, implementation challenges and outcomes. So what are the future directions and why government chose MR versus MMR for this particular campaign, that also needs to be discussed. So that completes the first part, and the last question was IMNCI in a less than 2-month-old infant. I think those who are in our subscriber group would be lucky enough, because this is the group. I would, yeah. So the exam happened on 15th of May, and fortunately, by luck, I would say, on 9th of May, I had posted an answer for IMNCI latest guidelines. And those of them who opened and read this and went for the exam would be feeling very lucky inside. So here is the flow chart. In IMNCI, basically what we follow is the assessment, followed by classification, identification and treatment. So the assessment protocol includes history and physical examination. History, they have mentioned it as the word ask, and physical examination by look, listen and feel. Then the classification protocol includes color coding. That means color green, it is a mild illness which can be managed even in the peripheries. Color yellow needs close monitoring and potentially deteriorating case. And color pink, you have to administer first line therapy and immediately refer the patient. So, and the question actually focuses particularly on less than 2 months. So there are two categories in IMNCI. One is 0 to 2 months and the other is 2 months to 5 years. So in 2 months to 5 years, the childhood diseases like diarrhea and pneumonia are given more importance. Whereas in young infants less than 2 months, the categorization goes as follows. The possible bacterial infection is one category, where you have to see that the possible serious bacterial infection is there or not. Then jaundice, hypothermia, diarrhea with or without dehydration, and the nutrition status. So these parts need to be highlighted in the IMNCI from 0 to 2 months. One example for condition of diarrhea and dehydration with or without dehydration, that is green, yellow as well as pink, all three categories comes under one syndromic diagnosis of diarrhea, that I have discussed in detail. You can quote this example in your answer also, and that would be sufficient. So that completes the discussion on first paper. I think in subsequent videos we can discuss on the second paper. So coming back to this particular question on how to write on the theory exam, one thing I would like to mention to all the students is to try to cover the answer in entirety. I mean to say, if a particular disease is asked and you know the pathophysiology very well, don't waste your entire time in writing only the pathophysiology, leaving the clinical features, the important lab diagnosis and treatment. You have to cover the answer in entirety. Even if you know one particular part more, you cannot keep on writing only on that. Second, focus on side headings. In the answer, you might have seen that the headings which are in blue color and brown color, they are the words which the examiner or the assessor will be searching for in your answer. If you cover all those points and you write a little bit of text in front of it, that will fetch you more marks than writing the stories or paragraphs. And surprise questions, obviously you have to keep at last. You have to use your common sense and try to write as much as possible. Like in this paper, the open access journal was a surprise question. You can use your common sense and answer that particular question. Try to write neatly and in points rather than in paragraphs, as I mentioned. And I hope your hard work will always pay when you use it more smartly in those 3 hours. So thank you, and we shall meet again in the next video.